Hi everyone, I'm Jill and I decided to do my clinical presentation on chronic lymphocytic leukemia, which is commonly referred to as CLL. Characteristics of CLL are that it is an indolent lymphoproliferative neoplasm. So indolent refers to it being slow growing, and lymphoproliferative refers to the overproduction of lymphocytes, and then neoplasm essentially just means overgrowth. So in CLL, there is a progressive accumulation of these functionally inactive malignant lymphocytes in both peripheral blood and lymph node organs. But CLL is also derived from B lymphocytes, which, as you might know, is part of the immune response. And it is a clinically heterogeneous disease, which means that some patients may have this disease so slow growing that it never limits life expectancy. But then others might actually have it much more aggressively that can even be treatment resistant. So it varies case to case. And then you could see in the image on this slide that there are CLL cells and then also malignant lymphocytes present in this cancer. So as I just mentioned, CLL is a clinically heterogeneous disease, but this heterogeneity is actually reflected at the molecular level because there are many diversities behind the genetic insults that can actually occur. So there can be either mutated or unmutated immunoglobulin genes, but approximately half of CLL cases actually show mutated immunoglobulin heavy chain variable regions. And then you can see in this image that this is what an immunoglobulin is, and you can follow the heavy chain up to the variable region, and that's often where these mutations occur in CLL. So on the contrary, there can also be unmutated IGHV cases. These can arise from a less mature cell rather than a mature B cell, which unfortunately has a much worse prognosis as opposed to when it's a mutated IGHV. So aside from these heavy chain variable regions, other sources that can contribute to CLL can be defects of tumor suppressors or overactivation of oncogenes and other things that we've already talked about like that. So CLL is the most common leukemia and makes up about 30% of all leukemia cases. In fact, there's about 2 to 6 new cases per year per every 100,000 people. And just in the US alone, there's approximately 15,000 new cases yearly. So it is fairly common. Along with that, it's more common among Caucasian men who are around 70 years old. And there can be an inherited predisposition. However, most cases are sporadic. And this chart that's on the screen here mostly just sums up what I just said, but you can see US, if you add those numbers, it's about 15,000 cases per year, and it seems that there are more men that tend to be diagnosed with this than women. So about a third of CLL patients don't present with any symptoms. And it actually tends to come up by chance with blood work when the doctor will notice leukocytosis, which is just an elevated white blood cell count. However, for the patients that actually do present with symptoms, the symptoms often are enlarged lymph nodes and spleens. And these can be detected with palpating the area, but then other symptoms include fatigue, shortness of breath, bleeding, infections. And then even a small minority of patients might present with fever, night sweats, or unintentional weight loss, and those are fairly common symptoms among other cancers as well. So the patient in this case is Patricia O. Halloran, and she is a 68-year-old woman. She had no health complaints, but when she went in for a physical exam, the CBC showed that she had a mildly elevated white blood cell count of about 18,000 cells per microliter. And the normal amounts are usually 4,500 to 11,000 cells, so hers was quite higher than that. However, her other blood counts for red blood cells and platelets, all that stuff, those were entirely normal. So her blood was sent to flow cytometry to determine whether these lymphocytes were normal or potentially malignant. And flow cytometry is usually the go-to method when confirming CLL. And you do need to confirm CLL cases because other conditions, such as infections, hyperthyroidism, reactions, things like that, they can also cause lymphocytosis. And in doing flow cytometry, a diagnosis of CLL would require at least 5,000 clonal lymphocytes per microliter. So in testing lymphocytes for clonality, they look for uniform expression of either kappa or lambda light chains, and predominance of one light chain will suggest monoclonality. And then along with this, the typical proteins on the surface of CLL cells are CD5, CD20, CD19, and CD23. And then in the bottom right of this screen, you can see that that's a sample of a flow cytometry. So the results of Pat's flow cytometry was that 60% of the lymphocytes carried only the lambda immunoglobulin light chain, and it lightly expressed CD20 and strongly expressed CD5 and CD23. And this confirmed a CLL diagnosis. So FISH was then used to do a cytogenetic analysis of the leukemia cells. You could see it pictured in the bottom right of the screen. And then in doing this, they saw that there was a deletion of chromosome 13q14 in 28% of the lymphocytes. And this is actually the most common recurring chromosomal abnormality, and it's the most favorable for survival of CLL cases, which is great for Pat because others could definitely lead to a much worse prognosis. And this is the Ray staging system used for CLL, and it employs only a CBC and a physical exam to determine the clinical state of the CLL. So currently, as I listed on the last slide, Pat is in stage 0, where she has circulating lymphocytosis, but she does not have any other symptoms such as an enlarged lymph node or spleen. But you can see in this chart that later stages have increased symptoms and with that lessened survival years, especially when you get to those stages of 4 and 5 where there's a higher risk diagnosis. In terms of treating CLL, most patients will often just be observed but will never actually require chemotherapy. However, if symptoms develop or worsen, then there would be cause to begin treatment of some sort of single agent chemotherapy or monoclonal antibodies that would, for instance, target the CD20 antigen on the lymphocytes. But in rare cases, Richters can occur, and this is a transformation when the CLL transforms into a more aggressive lymphoma. And this would definitely need treatment if that were to occur. So Pat remained asymptomatic and without any low blood counts of her red blood cells and platelets for the next 17 years, actually. So along with this, though, her white blood cells were still slowly rising. And at 83 years old, she felt very fatigued and was just having difficulty doing her daily activities. And it turned out that her white blood cell count actually increased to 233,300 cells per microliter. And then FISH was performed again and displayed that along with the original 13q14 deletion that was seen before, there was now an additional 17p13 deletion. So she was then put on treatment, but fortunately responded very well to it, and her energy improved along with her white blood cell count plummeted to around 4,000 cells per microliter. So sometimes relapses may occur, and these can just be treated with chemotherapy agents and combinations of treatments. And this actually happened for Pat. So 2 years after her positive response to that treatment, she started displaying symptoms of swollen lymph nodes, anemia, and increased spleen size, along with an increased white blood cell count. So she was prescribed ibrutinib, and then in taking this medication, her white blood cell count went down and her symptoms improved to normal. So she's been taking that daily for 2.5 years, and she plans to remain on it for as long as there's no evidence of CLL recurring. So, as far as CLL management goes, there's no current cure for it. The goal of CLL management is just to preserve a normal life expectancy and quality of life through those treatments. And studies are currently looking into whether ibrutinib, which is what Pat was on at the very end there, whether that can be an appealing initial treatment for CLL in younger patients. And there are additional promising agents for CLL, including targeting BCL2 or PI3 kinase.